Hello, my name is Demircioglu and I am doing a presentation on FBS2 Case 2. In this case, we have a 3-year-old male that has been stung by a bee and is showing signs of acute redness and swelling on his arm. The child is febrile, which means he does not have a fever and is showing signs of difficulty breathing. Whether it may be from bronchoconstriction or swelling of the tongue or both, the case does not specify. However, the doctor categorizes this as a severe allergic reaction, and thus the attending injects the child with 1 in 1,000 epinephrine subcutaneously in order to assist the child to breathe better. In this case, if the mother would have not brought the child to the emergency room, the child would have developed a very severe anaphylactic type shock, and the chances of survival for the child would have been much worse. Another thing to consider in this situation is that the children do not have compensatory factors like teens and adults do, so they will not show signs of decompensation, hence why the doctor needed to act quick because there is very little window of opportunity. First question is, describe the process of inflammation that might have led to swelling. There is a saying, type 1 is first and fast. This is a result of type 1 hypersensitivity reaction. What happens here is that IgE is formed as a result of prior sensitization, whether it may be from previous contact, or this can also be passed down to the offspring via genetics. Subsequent encounter with an antigen would result in an IgE-mediated reaction by preformed IgE antibodies. This means that the more exposed you are, then over time, the more severe the allergy reaction will become. From here, the free antigen binds to two adjacent antibodies, known as cross-linking, and this would result into degranulation of cells. This would result in release of histamine and other mediators such as prostaglandin, platelet activating factor, leukotrienes, heparin, and tryptase. The release of histamine would then result in increased smooth muscle contraction, peripheral vasodilation, and increased vascular permeability, which will also result in, if left untreated, hypovolemia and hypoxia. De-extravasation, meaning leakage of a fluid out of its container, out from the capillaries, would result in erythema, which is redness, and fluid shift into the interstitial space would finally result in edema. In very bad scenarios, you can also expect to find pulmonary edema, which is a fluid accumulation in the lungs, which, if that is the case, the patient wouldn't be able to lie down at all. Next question is, enumerate the mediators of pain, edema, and redness. As mentioned from the previous slide, that histamine is the most mediator when it comes to type 1 hypersensitivity. Histamine is a vasoactive amine and inflammatory mediator released during mast cell degranulation. Excess activity mediates symptoms of anaphylactic reactions, including hypotension, swelling, erythema, and bronchospasms. However, there are other mediators as well. Prostaglandin is a group of signaling molecules derived from arachidonic acid with a wide variety of functions, including inflammation and cervical ripening. Platelet activating factor is a pro-inflammatory cytokine produced by various cells of the immune system, such as neutrophils, monocytes, and macrophages, involved in platelet aggregation and the development of septic shock and bronchoconstriction. And finally, leukotrienes are a group of inflammatory mediators produced by leukocytes that potentiate allergic and asthmatic responses, meaning that they make the reaction worse. And as for pain, wherever you have swelling, you will also likely have pain in the area as well. Next question is, describe the vascular and cellular changes during inflammation. In regards to vascular changes, you will have larger blood vessels, which means that there would be more room for blood contents, like plasma and blood, to go into. Imagine if you were to give nitroglycerin sublingual. Nitro is a potent vasodilator. It will increase the amount of fluids in the blood vessels and less blood flow going to the heart, thus reducing cardiac output. The same can be said with histamine being released and causing systemic vasodilation. Note that these patients can develop orthostatic hypotension. However, in this case, there will also be vascular permeability, which will get blood from extracellular to the intracellular space. There is another term for this. It is called third spacing. This can also cause hypotension. An example of this type of reaction is an adverse reaction when patients take a combination of diphenhydramine and metoprolol. This reaction can cause patients to third space and may also result in additive effects on blood pressure. The characteristics that we can see with cellular changes upon an inflammation response is necrosis. Apoptosis does not occur during an inflammatory response. During an inflammation, there is membrane damage in which cells will have an influx of calcium. There will also be organelle swelling. With the mitochondria and endoplasmic reticulum damaged, there will be an inability of cells to produce ATP and release of ribosomes into the cytoplasm, which will release digestive enzymes, and there will be a loss of RNA. Nuclear shrinkage will also occur, which is called pycnosis, then fragmentation, which is called karyoexis, then disintegration, which is called karyolysis of the nucleus, and finally autolysis, which is the destruction of cells or tissues by their own enzymes. In microscopy, you can see cell swelling, cell blebbing, cell organelle destruction, and nuclear changes. Then the cell will burst and it will cause inflammation. After, there will be degradation of necrotic tissue by leukocytes, and then there will be organization of granulation tissue generated by fibroblasts during wound healing. Next question is, mention the type of shock the child is presented with and why epinephrine is an ideal choice in this setting, and elaborate its mechanism of action. So the child in this scenario, as I have stated in my previous slides, is having breathing problems. When you have breathing problems mixed with an allergy reaction, you can think of an allergy reaction like an allergy reaction about to occur. Thankfully, the child in this case is only in the early stages of the anaphylactic shocks. This is an indication to use epinephrine. Epinephrine can be used either IV, intramuscular, or subcutaneous. The IV solution would be a concentration of 1 in 10,000, while the intramuscular and the subcutaneous doses are set to 1 in 1,000. We know that in this scenario, the child has difficulty to breathe due to bronchoconstriction. In order to dilate the bronchi, you will need a beta-2 agonist. If you look at the mechanism of action of epinephrine, you can see in red that the drug is a moderate beta-2 agonist. Note that if you also stimulate the beta-2 receptors, the mast cells will stabilize, causing inhibition of histamine release, which would be an added bonus to the child's situation and will help with the prognosis. Next question is, plot the drug response curve of epinephrine with and without the presence of beta blockers. On this slide, we have a picture of a beta receptor and a response percentage versus log dose of drug chart. What we can see here is that if the competitive antagonist is introduced, then the potency of the drug epinephrine, the agonist in this situation, will become less potent, and thus you will need to give more of the drug, which is the Km variable in this chart, in order to have the same efficacy. Something to note here also is that if the antagonist is more in numbers, then the agonist will not be able to bind to the receptor site. Only when the agonist is greater in numbers, then the antagonist is when the agonist will be able to bind to the receptors. Next question is, what type of hypersensitivity reaction is seen in this child? This type of hypersensitivity reaction is due to the cross-linking of which immunoglobulin on mast cell surfaces. You may have heard me say this before. Type 1 is first and fast. This is the pathophysiology of type 1 hypersensitivity reactions like anaphylaxis, food allergies, drug reactions, which can be severe enough to result in anaphylactic shock. And it is mediated by inflammatory mediators like histamine that instantly trigger a hypersensitivity reaction, and is triggered by the cross-linking of an allergen with the IgE, which signals the immune cells to degranulate. IgE is typically bound to FcR, which is a membrane receptor protein found on many cells, on the surface of immune cells such as mast cells and basophils. Next question is, which cytokines promote class switching of B lymphocytes to IgE? In order to answer this question, we first need to understand what are cytokines. They are signaling proteins that modulate immune responses, inflammation, differentiation, and hematopoietic cell proliferation, such as blood cells like erythrocytes, leukocytes, and platelets. There are many, they are mainly secreted by hematopoietic cells and can act in an autocrine, which means same cell, paracrine, which means the cells around it, or endocrine mode, which is system-wide. They are classified into pro-inflammatory cytokines like interleukins 1, 6, 8, 12, and 18, and anti-inflammatory cytokines such as interleukins 4, 10, 11, and 13, and transforming growth factor beta. The cytokine that promotes class switching of B lymphocytes to IgE is done by interleukin 4. These are my references that I used in this presentation. Thank you for listening and have a great day.